happy to be here tonight. You've heard a lot about diagnosis and treatment of gynecological cancers. The emphasis in genetic counseling is more on prevention of cancer, especially in people who have an inherited predisposition to specific cancers. So people are usually referred to a genetic counselor because either they or their doctor has noticed either a pattern of cancer running through their family that exceeds what you'd see in the average family, or perhaps because they or a family member was diagnosed at a very young age, or perhaps because they or a family member has had more than one kind of cancer. So some of these individuals who come to a genetic counselor will have what we call a hereditary cancer syndrome, or an inherited predisposition to specific types of cancer. And these cancer syndromes are caused by an inherited mutation or flaw in a single gene, which can often be detected by genetic testing. So you may be wondering, why would anybody want to undergo genetic testing to find out they're at high risk for a potentially life-threatening disease? And the reason being, especially for those who are unaffected or have unaffected family members, is that there are often preventive measures that can be taken to reduce the risk or eliminate it altogether. So these effective measures to prevent cancer, once a genetic mutation is found in a family, the benefit of knowing what the underlying cause for cancer in the family is can be extended to an entire family by doing targeted testing for that mutation. So this slide shows a pie chart showing that cancers can be categorized, and it shows that the majority of cancers are what we call sporadic. That they are cancers that occur to an individual who has no family history of that type of cancer, and they're believed to occur by chance or due to environmental causes. And most of these sporadic cancers occur later in life, but not always. Then about 25% of people who develop a cancer diagnosis do have some family history of the same kind of cancer, but we can't identify a single genetic factor underlying the cancers in the family. So we say they have familial risk, and it's assumed that the familial risk is due to multiple genetic and environmental factors, each of which could increase the risk for cancer a little bit, but put together increases the risk maybe 2 or 3-fold over that in the general population. So the amount of familial risk you might have in your family, if you have family history, depends a lot on how many relatives have cancer and how closely they are related to you. So for example, if you have a couple of cousins with the same kind of cancer, that wouldn't increase your risk nearly as much as if you had a sibling and a parent with the same kind of cancer. Okay? So the smallest piece of the pie, about 10% of cancers, are due to a single gene mutation that's inherited in the family and causes a hereditary cancer syndrome. Oftentimes, as I said, these cancer syndromes can be tested for, and we can find the underlying mutation. And usually if we look at the family history of someone with a hereditary cancer syndrome, it's going to be much more dramatic than someone with familial risk. So this is the family history of a woman I saw recently. This circle at the bottom represents my patient, who was a 59-year-old woman with endometrial cancer. And if we look at her family history, the people in the same line as her are her siblings, and up above we can see her mother and father, and it just shows her father's siblings and her father's parents. So what we see going down one bloodline in her family, the paternal bloodline, is that she's got 2 siblings with colon cancer, a father with colon cancer, an uncle with colon cancer, and an uncle and an aunt with stomach and ovarian cancers, respectively, and then her grandmother, paternal grandmother, with endometrial cancer. So it's a lot of cancer in one family, and so the question is whether or not a family like this, whether we can do genetic testing to find the underlying cause in the family of these cancers. And the benefit to the rest of the family, if we can, is that someone like my patient's 45-year-old sister who has not had any cancer can find out what specifically she might be at high risk for if she did inherit the genetic mutation that's caused all these cancers, or if she has a 50-50 chance of inheriting the mutation. If she got lucky and did not inherit it, then in spite of her strong family history of cancers, she can rest assured that she has just the general population risk for uterine and colon, ovarian, stomach, etc. So these are some of the hereditary cancer syndromes that I see in my work. And I have not, purposely have not put names of genes on these syndromes. First of all, they can be difficult to remember, and also it's an evolving science. So today we may know of, say, four genes that cause Lynch syndrome, but more genes may be discovered, and so it's just as well that I not complicate things by adding a lot of gene names. But one of the things you might notice on this slide is that with regard to gynecological malignancies, ovarian cancer and endometrial cancer occur at higher rates in more than one of these syndromes. So the take-home point from this is that if you do visit a genetic counselor to see if there's an underlying syndrome in your family, it's really important to get an accurate family history before going, because that will determine which syndrome and which genes associated with the syndrome the genetic counselor would test. So we don't want to go barking up the wrong tree and say, no, you don't have risk for endometrial or ovarian cancer, when in fact we may have an inaccurate family history and want to test you for Cowden syndrome instead of Lynch or hereditary breast and ovarian. So just as an example, sometimes people will just know that a family member had some sort of uterus cancer of the uterus. And to a genetic counselor, there's a huge difference between an endometrial cancer that develops in the lining of the uterus and a sarcoma, a uterine sarcoma that develops in the muscular layer of the uterus. They represent, or they occur in different syndromes, and so we would test different things. Okay? I'm not as good without notes as my colleagues here, so you'll bear with me if I check my notes. Okay. So, next slide. So the cancer syndrome that gets the most risk, the most attention in the media is hereditary breast and ovarian cancer syndrome, which is caused by the BRCA1 and 2 genes, among other genes that we'll be talking about. But it may surprise you, in spite of the fact that it gets more attention, that the second syndrome here, Lynch syndrome, is actually about twice as common. It's about twice as common, but it's more often undiagnosed. And that's unfortunate, because the cancers associated with Lynch syndrome are oftentimes very preventable. If people know they have the syndrome before developing a cancer, there are preventive measures they can take. So Lynch syndrome is associated with very high risk for colon cancer, although I should let you know that in recent years, one of the things that has come to attention is that amongst the different genes that can cause Lynch syndrome, about half of them cause really high risk for colon and endometrial, and then the other half cause only moderately increased risks. So now the medical guidelines for managing people with Lynch syndrome have been divided into sort of the higher risk management guidelines and those for the lower risk people. So in actual fact, with some of the genes for Lynch syndrome, the colon cancer risk might be as low as 20%, but that's still significantly higher than the average person's risk. So because the risk is elevated for both colon and uterine in women with Lynch syndrome, about half of women with Lynch syndrome are going to present with a gynecologic cancer first, such as usually with uterine, but sometimes because the risk is elevated for ovarian, they may present first with ovarian cancer. There is variable but much smaller risk for the other cancers here, and it does seem to vary a great deal with what gene and what your family background is. So there are modifying genetic influences that can determine what the risks are in a given family. So I just put that little thing about over 600,000 people in the United States alone having Lynch syndrome and only about 5% being aware, which is kind of mind-boggling, and one of my pet projects is to raise awareness. We have a Lynch syndrome pre-screening program or protocol in place at John Muir Health, where anyone who's diagnosed with either a colon or a uterine cancer has their, at the time of surgery, there's some screening tests that are done on the tumor tissue itself that can give us some clues as to whether this tumor might be associated with Lynch syndrome and whether it might be a good idea when the patient recovers to go to a genetic counselor and pursue that further. So this is the pedigree or family history I showed you before, and now that you know about Lynch syndrome, you can probably recognize that this family does have Lynch syndrome. And let's see. One of the things I wanted to mention about Lynch syndrome is it used to be called HNPCC, or hereditary non-polyposis colorectal cancer, and that was because there was less awareness of the fact that the gynecologic cancers, that the risk for gynecologic cancers is as high as it is, and so Dr. Henry Lynch brought that into our awareness more, and that's why we call it Lynch syndrome now. So one of the things I did want to point out here is that one of the clues to a syndrome is the fact that we see all of these related cancers in a single bloodline. So sometimes when people are concerned about family history, it's important to keep in mind, are they all on one side of the family or are they spread out? Not that you could not have inherited risk coming from both sides, but that's rather rare. So surveillance and prevention guidelines for Lynch syndrome, as I mentioned, are evolving all the time. And so what I've put on this slide is kind of a baseline, but as I mentioned, we do have slightly different guidelines for the milder forms of Lynch syndrome. We do recommend that women with Lynch syndrome, once they're finished having children, strongly consider having a preventive or prophylactic hysterectomy and bilateral salpingo-oophorectomy. For women who are still young enough that they are considering having children, one of the things I believe Dr. Pike mentioned, that two-step process where they, I think you mentioned it, it's becoming more accepted for the premenopausal women who have higher risk for ovarian cancer, to remove the fallopian tubes, allowing them to still retain the ovarian function so that they can produce eggs, which would have to be harvested and then introduced to artificially to the uterus after fertilization in vitro. But that does allow a young woman who finds out she has Lynch syndrome to still bear children, and then later on when she's done with that, have those organs removed. We don't have really good data for the effectiveness of upper endoscopy, so the guideline for catching the stomach or small bowel cancers. So that's something that's done on a case-by-case basis, and we sort of recommend screening that is that goes along with what cancers have been seen in the family, as well as which gene has a mutation. So it's kind of a very tailored to the individual person. So I'd like to talk a little bit about the hereditary breast and ovarian cancer syndrome, which you probably heard a lot about in the news this past couple of years. Angelina Jolie came out publicly as having this syndrome and told her story, which raised a lot of awareness. So while this particular syndrome, having inherited risk for breast and ovarian syndrome, is usually associated with BRCA1 and 2, we now know of a number of other genes that we have testing for. Most of these genes are in the same pathway in the cells. So they work along with BRCA1 and 2 in a couple of very important functions. We all have these genes, so when we do genetic testing, we're not looking to see, do you have a BRCA1 gene or not? Everybody, male or female, has a copy that they've inherited from their father and a copy from their mother. We're looking to see if they're functioning normally. The normal function of these two genes is twofold. Number one, they help regulate the cycle of cell growth and division. If you look at the difference between a normal cell and a cancer cell, normal cells have very tight regulation for how often they can grow and divide, and then at some point they die off and new cells take their place. In cancer cells, we don't have that tight regulation. It's sort of chaotic, lack of regulation. So what can happen if you have a mutation in a BRCA1 or 2 gene is one copy of the gene is not providing that regulation of the cell cycle, and if anything happens to the other copy in a given cell, that cell is then more likely to start forming a tumor or becoming a cancer cell. The other function of BRCA1 and 2 is to help repair certain types of damage to the DNA, and that's another thing that's very different between normal cells and cancer cells. Normal cells, if the DNA gets damaged, it gets repaired before the cells divide again. So there's not the perpetuation of DNA damage as cells divide. But in cancer cells, you get the accumulation of a lot of DNA damage. And that's one of the reasons why they're so chaotic and So when a woman comes to me asking me, I want to find out if I have the cancer gene, I first have to reassure her that she has them, thank God. We just want to make sure they're working right. Males also can have this syndrome, although the risks to males are not nearly as high. So with males who, well, I guess I'm jumping ahead of myself. Let's back up a bit. The characteristics of this syndrome, or what might make you want to be evaluated for it. Anybody in the family or yourself with an ovarian cancer diagnosis, that's a good indicator to go and have testing. Because the spread in ages of diagnosis is really quite wide. We do tend to see more women diagnosed premenopausally with ovarian cancer if they have a BRCA1 mutation, but other than that, I've seen women, especially with BRCA2 mutations, diagnosed in their 70s and 80s. An early, say, premenopausal diagnosis of breast cancer is usually a good reason to be evaluated for these genes. A family history of both breast and ovarian cancer is a very good indicator. And also bilateral breast cancer, as a bilateral meaning there are two separate tumors have arisen, maybe not at the same time, maybe a few years after. One in the right breast, one happens in the left breast, and it can be shown pathologically that it's not a spread of the initial tumor, but a brand new cancer. And then certain populations that have been reproductively isolated. In other words, they may have cultural, religious, or even geographical reasons why their gene pool stays confined, not diluted by other populations. The Ashkenazi Jewish population would be an example where for hundreds of years they mainly intermarried with each other, and so any genetic mutation that's in a group like that can grow to have a much higher frequency. So it just so happens that with the BRCA1 and 2 genes, there were mutations in the Ashkenazi Jewish population that grew to a higher frequency, so that we see about 2% of Ashkenazi Jewish people having a BRCA1 or 2 mutation. That includes men, whereas the frequency is only about 1 in 400 or 500 in other groups. Any person with male breast cancer should get tested as well, since that's a really rare cancer in the general population, and males with BRCA2 mutations can have about 8% lifetime risk, still lower than the general population risk for female breast cancer, but certainly higher than the usual risk. So sometimes people ask me, can a cancer gene skip generations? And the answer is no. The genes don't skip generations, but they can be carried silently, especially if they're carried by a gender that wouldn't be more likely to develop breast and ovarian cancer. And so this is a family history of a young woman I saw when she was diagnosed at age 47 with ovarian cancer, and she had no family history whatsoever of breast or ovarian cancer. So at first glance, she looks like she has a sporadic cancer. But if you take a closer look at the paternal side of her family, neither her father or her paternal grandfather had any siblings. So no females for 2 generations. And when we tested her, we found out that she did carry a BRCA1 mutation that she had inherited from her father. We knew this because after we found the mutation in her, we then tested her mother, and her mother did not carry it. So this is a gene that has a very, very, very low rate of de novo or brand new mutations. So we usually assume that if one parent doesn't have it, the other does. And of course, males who carry BRCA1 mutations are usually silent carriers. So the management of cancer risk in someone who's been identified as having a BRCA1 or 2 mutation, or how can we lower the risks further, especially if we find out they have that genetic status before developing any cancer. They can be looked at as going in 3 categories. The first would just be the least invasive, which is increasing surveillance. So for women who have high risk for breast cancer, which can be anywhere between, say, 50 to 85% lifetime risk, depending on the family, because these mutations do not affect all families the same. Starting mammography at a younger age is recommended, and alternating mammography with breast MRI at 6-month intervals, as well as having a clinical breast exam, very thorough clinical breast exam every 6 months, is what a lot of younger women who are not ready to do any risk-reducing surgeries might choose. The risk-reducing surgeries that are options would include a preventive bilateral mastectomy with or without reconstruction, which of course reduces the risk of breast cancer the most, and it's an option that's chosen by probably half of the women who test positive. I'm talking specifically here of women who have not had a cancer diagnosis. They're what we call previvors. They know they're at high risk but have not had a cancer yet. So, but it can be a very difficult choice, especially for a young woman if she has not found her lifelong partner yet and has not had children and is looking forward to having children and breastfeeding and all of that. It can be a very, very heart-wrenching decision to decide whether or not preventive mastectomy is something she wants to do or wait for that. And then, of course, we've had a lot of discussion about the salpingo-oophorectomy, and that, as I mentioned with Lynch syndrome, is also recommended to reduce ovarian cancer risk in hereditary breast and ovarian syndrome. One of the other benefits of removing the ovaries if you're premenopausal is that it also reduces the breast cancer risk by approximately 50%. Kind of depends on how premenopausal you are, but say a 40-year-old woman removing her ovaries has reduced the amount of circulating estrogen to the point where her, even if she takes back low-dose hormones to prevent going into a surgical menopause, will be significantly reducing her breast cancer risk. Chemoprevention refers to drugs that reduce the risk of developing cancer. So it's different from chemotherapy, although sometimes we use drugs like tamoxifen is often used in cancer treatment, but it can also be used as a preventive medication. Chemoprevention for ovarian cancer, as I believe one of the other speakers mentioned, oral contraceptives are usually recommended for young women who are not ready to remove their ovaries if they're not actively trying to get pregnant, or it's recommended that they reduce their ovarian cancer risk by taking oral contraceptives. And chemoprevention for breast cancer usually involves taking a medication that reduces the exposure of breast cells to estrogen. So tamoxifen is one of those options. So just to summarize, people who have a lot of cancer in their families or an early diagnosis are potential candidates for genetic counseling and an evaluation for whether there is a hereditary cancer syndrome in their family. And the advantages to doing that are, as I've mentioned before, that there are preventive steps that can be taken to be proactive and lower your risks or eliminate them altogether. Thank you.